My name is Jasmin Fuentes, and today I will be presenting the project I worked on for MPLD. It was related to evidence-based practices in the child welfare scenario. I worked specifically with the trauma-focused cognitive behavioral therapy. This is me. Like I said before, my name is Jasmin Fuentes. I'm a social work specialist in the Children and Family Administration of the Family Department of Puerto Rico. I have 23 years of experience working with child welfare, 21 which have been within this agency. What is an evidence-based practice in child welfare? Evidence-based practice involves identifying, assessing, and implementing strategies that are supported by scientific research. As you can see in the diagram, it is the integration of the best available research evidence, the client's characteristics, needs, values, and preferences, and the resources available, which include the practitioner's expertise. The environment and the organizational context are also taken into consideration. Research shows that EBP make it possible that families be referred to the most scientifically researched and effective programs their communities provide. It also helps child welfare workers and their supervisors empower families so that when they are in crisis, they will be able to resolve their own conflicts. It can cause families to make a greater commitment to participating, which is essential to the process. And it helps the workers know about the range of programs that are available in their areas, letting them make informed choices when referring families. Family First Prevention Services Act is a federal law that seeks to prevent the separation of families by providing trauma-informed and evidence-based services in the areas of mental health, substance abuse, and home parenting skills. At the moment, Puerto Rico is in the initial implementation phase of Family First. I have worked in child welfare for 23 years, and learning about evidence-based practices makes me think about how much more I could have helped some of the families under my attention when I was a caseworker. Whenever possible, Family First seeks to have children remain in their homes. Working in Puerto Rico with the implementation process made me realize how important evidence-based practice services are for the well-being of the children and families that we serve, and how they can help prevent the entrance of children into the foster care system. In this project, the TF-CBT sought to help the children and the parents who experience domestic violence. The PICO established for my project read as follows. If parents who are currently involved in the child welfare system with in-home cases and who have experienced domestic violence receive trauma-focused cognitive behavioral therapy for themselves and their children, will it reduce trauma symptoms in the children and provide parents with tools to stabilize their family? We will be able to see the results at the end of the presentation. The initial data collected states that these were the amount of in-home cases and foster care cases in 2020 and 2021. The information you see for 2022 reflects the number of cases by March 2022. I was interested in collecting data about how many in-home cases become foster care cases each year, but there was no official report that provided such information. So this is a gap area that I was able to identify in my agency. The intervention in my program was based on trauma-focused cognitive behavioral therapy, which, as I explained before, is an evidence-based practice that is focused on trauma. Psychotherapy services were provided by 3 students from Ana G. Mendez University who were completing their master's degree in clinical social work. The in-home cases that received these services were from Bayamón region offices, specifically the Bayamón 1 and 2 local offices. TF-CBT goals are to enable children and youth who have experienced serious traumatic events and their supportive caregivers to be able to learn skills that help them cope with trauma-related emotional and behavioral issues, to help them face and resolve those issues in a safe and therapeutic way, and to be able to integrate their trauma experiences as part of their lives and help them move on with their lives in a safe and positive manner. I would say that the goal is to help them realize that the trauma does not define them or their lives, that it is something that they went through, but that does not define who they are. TF-CBT can be used with children between the ages of 3 to 18 years old. It can be used with all demographic characteristics, meaning children from any racial, ethnic, culture, or country of origin. To the date, there is no demographic group for which TF-CBT has not been found to be effective. There should be present a history of traumatic events and other trauma-related problems, such as depression, anxiety, fear, self-blame, behavior problems, sexual behavior problems that are related to the trauma or traumatic grief. The children may present significant PTSD symptoms, but it is important to point out that the child does not have to meet the full diagnostic criteria for PTSD. The therapy can be used successfully with co-occurring difficulties such as ADHD, oppositional defiant disorder, and other conduct disorders. To be able to implement this therapy, the parent-caregiver involvement is essential in the process. This therapy has shown a wide range of improvement that includes decreases in the PTSD symptoms, in depression and anxiety symptoms, in behavior problems, cognitive disorientation, and relationship difficulties. Parents have experienced reduction in their own emotional distress and depressive symptoms, as well as improvement in how they can support their children and manage their children's behavioral difficulties. TF-CBT helps children, youth, and their parents overcome trauma-related difficulties, including child maltreatment. It also addresses upsetting beliefs and helps them learn skills to be able to cope with ordinary life stressors. It has shown improvements in child being able to better their behavioral problems, including sexual behavior problems that are related to the trauma, and with improving the child's adaptive functions. It has also been found to enhance parent-child communication and attachment, increasing the parent's ability to maintain safety for their children. It also helps to increase parent skills and parental support of the child by reducing parental distress. Research supports the efficacy of TF-CBT. In many studies, this therapy has been found to be an effective treatment for children and families from diverse culture and ethnic backgrounds. It has received the highest rating for effectiveness from several independent rating programs, such as California Evidence-Based Clearinghouse for Child Welfare, the OVC Guidelines Project, and the National Registry of Evidence-Based Programs and Practices. It is currently being evaluated for effectiveness in Latin America and the Caribbean. As recently as this last July, 2022, a study titled Trauma-Focused Cognitive Behavioral Therapy with Puerto Rican Youth in Post-Disaster Context, Tailoring, Implementation, and Program Evaluation Outcomes was published. In this study, the objective was twofold. First, to train mental health providers in Puerto Rico in TF-CBT, and second, to conduct a program evaluation to determine the possibility of implementation and if the treatment could be effective. 36 out of 56 children enrolled in the project successfully completed therapy. The results demonstrated large effect sizes of a reduction in youth-reported post-traumatic stress symptoms, depressive symptoms, and anxiety symptoms. These results suggested that it was feasible to train providers in Puerto Rico on TF-CBT, that those providers were able to deliver the therapy in community-based settings, both in person and via telehealth due to COVID pandemic, and that this therapy was an effective treatment option to address trauma-related concerns for youth in Puerto Rico and in a post-disaster context. So who participated in this project? Well, 10 families with active in-home cases due to domestic violence in presence of children. 9 of these 10 families completed therapy. A total of 15 children completed therapy. We had 7 children between the ages of 3 to 6 years old, 3 children between the ages of 7 to 11, and 5 children between the ages of 12 to 17. TF-CBT has been found to be effective in as few as 8 sessions and occasionally may extend as many as 25 sessions. However, in most cases, it should be completed within 12 to 20 treatment sessions that usually last between 45 to 50 minutes. This therapy should be delivered in a weekly treatment sessions or more frequently, let's say maybe 2 sessions per week, but it should never be delivered less than once a week. The 9 families that completed therapy in this project received an average of 12 sessions. The methodology and process began by training the master students in TF-CBT. The training was provided by the Medical University of South Carolina. Next, cases were identified through discussions between the local office caseworkers and supervisors with the clinical social worker and myself. The cases were in-home cases in which children had witnessed domestic violence, and the caseworker had identified that this traumatic event had affected the child's behavior. After the cases were selected, the families were to be assigned to a therapist and introductions were made. As I mentioned before, an average of 12 therapy sessions were completed. Norm reference assessments were used to collect data at 3 points: baseline, midpoint, and endpoint. The 3 norm reference assessments were used to measure the impact of the therapy. According to American Psychological Association, norm reference assessments allow an individual score to be interpreted by comparing them with scores that are typical for a particular group. The 3 assessments that were used as part of the evidence-based practice process to analyze how well the program supported these children and their family were the Child and Adolescent Trauma Screen, the Screen for Children Anxiety-Related Disorders, and the Behavior Assessment System for Children. For children between the ages of 3 to 6 years old, the parents completed the CATs, and children 7 years and older self-reported. When using the SCARED, parents completed the assessment for children between 3 to 7 years old and children 8 years and older self-reported. The BASC was completely completed by parents in all 3 age categories. To analyze the data I provided, Sherilyn's team with the assessments in Spanish and English. The BASC I didn't have it available in English and was not able to find it online, so I translated the assessment for each of the age groups. In this final section, I will be discussing the evaluation and results of the project. Data was collected through surveys completed by parents, children, and master students. When surveying parents, we asked if the therapist showed interest in the parents' and family's need. 67% strongly agreed and 33% agreed that they did. 44% agreed and 56% strongly agreed that the therapy had helped them obtain skills to handle future problems. 33% agreed and 67% strongly agreed that therapy had helped their child. 8 of 15 children were surveyed. We only surveyed the children that were 7 years or older because we wanted to ensure that they will be able to answer these surveys by themselves. 38% of the children surveyed agreed, and 62% strongly agreed that their therapist let them participate in the goal decision process, while 13% agreed and 87% agreed that their therapist made therapy time fun. We asked both parents and children if they believed that completing the therapy process helped them feel better. 13% of the children and 44% of the parents agreed that therapy had made them feel better, while 88% of children and 56% of parents strongly agreed that therapy had made them feel better. When surveying the master students, all 3 completely agreed that they felt that their participation had made a positive contributions to the family served. They also felt that the number of families assigned made it possible to complete the total of hours required for their internship. 2 of the students completely agreed that the training they received prepared them to provide TF-CBT and indicated that if a paying working position were to open in the program, they would apply for it. As explained previously, the 3 norm reference assessments used were SCARED, BASC, and CATS. Only 2 of the scales were analyzed for this presentation. They were the BASC and the SCARED. The Child and Adolescent Trauma Screen data wasn't included in the analysis because there was not a variation in the responses from baseline to endpoint. Its basic purpose was to measure if the children had been exposed to trauma. On the aggregate analysis, we see that there was growth in positive behavior, which is the desired outcome. Of the four older children who showed significant positive change from baseline to endpoint, 2 showed no significant change and 1 had behaviors that still needed to be addressed even after completing therapy. Of the 5 younger children, 4 showed significant positive change and 1 had no significant change. To summarize, all 9 children responses from base, mid, and endpoint were added together and plotted on the graph presented here. The blue line shows the average scores of the children less than 6 years old, and the red line shows the average of the scores of children older than 6. On the aggregate analysis, we see that there was a decrease in negative behaviors for the scared instrument. This decrease is the desired positive change because we want their anxiety symptoms to decrease. Of the 2 older children with scores at all 3 times, 1 showed a significant decrease in negative behaviors, which implies an improvement in behavior from baseline to endpoint, and 1 had no significant change. Of the 4 younger children, 3 showed a significant decrease in negative behavior and 1 had no significant change. To summarize, all 6 children responses from base, mid, and endpoint were added together and plotted on this graph. The average scores are shown on the red line. As mentioned before, with this assessment, lower is better. These are an example of the results of one child's BASC results. We can see that in the column to the left, the rating improved from sometimes to almost always when referring to conducts like maintaining good visual contact when spoken to, presenting a sense of humor, listening carefully, answering when spoken to, starting conversations the correct way, being open to experimenting with new things, and smiling at others. In the column to the right, the rating improved from frequently to almost always in conducts like saying please and thank you, complimenting other people, volunteering to help, asking politely for help, and encouraging others. Here we have an example of results from the scared assessment for one child. The rating improved from sometimes to hardly ever when referring to conducts like not liking to be with people he or she doesn't know well and feeling nervous around them, following parents everywhere, being afraid to be alone in the house, and worrying that something bad is going to happen to their parents. In the future, we will look at this type of data and dive in even deeper into the outcomes achieved by each child across the different age groups and for all the children as one group. Here's a small summary of the results. 9 out of 10 families completed therapy. Families were able to learn effective skills to cope with trauma-related emotional and behavioral problems, face and resolve those problems in a safe and therapeutic way, and effectively integrate their trauma experiences and prepare to move on with their lives in a safe and positive manner. 2 of the lessons I learned were that the evidence-based intervention must be included in child welfare, and that it is important to evaluate and work with the trauma that families have confronted in their lives. When working in child welfare, we tend to work with the present problem or situation that is right in front of us at the moment, which is not a bad thing. But it is also important to dig a little deeper and look into the trauma that these families have gone through that could be a factor in the issues that they have at the moment. Some of the challenges confronted were the initial official data that was available because, as I mentioned at the beginning, there was a gap found when requested the amount of in-home cases that had become foster cases each year. Student schedules were another challenge because they had to complete their internships hours, had other classes, and 2 of them had full-time jobs. This made it a bit difficult to reschedule sessions when the parents canceled. Another challenge was that initially it was difficult to establish empathy between the therapist and the parents because of the parents' previous negative experience with child welfare system. What are the next steps? Well, the next steps are going to be first to assess the gap identified in the agency's data. Then I'm going to be presenting the results to my agency's leadership, and I will be continuing with the program to obtain more data that can support the development of a specialized unit in the agency that can provide therapy through clinical social work to families with active in-home cases. MPLD has impacted my life in a positive way. It has helped me grow as a person and as a professional by reinforcing my ability to feel comfortable with sharing my ideas and improving my time management. It has also made me more culturally competent and responsive to the needs of diverse children and families that receive services from the Family Department of Puerto Rico. It has reinforced the importance of evidence-based interventions in child welfare and has helped me give greater visibility to clinical social work within the agency. And last but not least, it has motivated me to create positive change in the agency where I work, having in mind the benefit of the families we serve. These are the references used to make this presentation. Thank you for viewing my presentation, and I'm sharing my contact information in this slide.